today.
Okay, well, thank you very much to the organisers for inviting me. It's nice to see you all. I've enjoyed what I've seen so far. So I've been given a very big area, very controversial area about managing the axilla. So I will do what I can. The early slides I might go through a little bit quicker to get through it and try and make the time. So I'll do my best, but the more interesting stuff is a bit later on. So as you can see, this is all it's a good picture of Donald Trump. I think a lot of people look at the axilla here as very confusing. Do we do a clearance? Do we do sampling, sentinel node biopsies, axillary radiotherapy, or do we not even bother operating on the axilla anymore? And of course, it's a bit of everything here, really. It depends on the circumstances. So I'll lead you through it. So at the beginning, everybody used to have an axillary clearance for every cancer presenting in the 1970s, 1980s, and even as late as the 90s. And it's still the standard procedure for women who present with radiologically or clinically involved lymph nodes, which you see a lot of over in Bangladesh and India. So, and the standard operation is a level 2 axillary clearance. You get a good number of nodes removed, at least 10, usually on average around 15. We also have evidence, which I'm not showing, but level 3 clearance does remove more lymph nodes, but there's no evidence that it leads to a better outcome. And of course, there's much higher lymphedema rates. So I think most of the surgeons here know the levels 1, 2, 3, so I won't dwell on those. And there's a little picture. I'd just like to highlight there's some interpectoral nodes, also called Rotter's nodes, and internal memory nodes that are left behind whether we do a level 1, 2, or 3. So we need to just be aware of that. They sometimes come back in those areas. So level 2 is the standard. And these are the side effects that Dr. Ali Nafis was talking about earlier. The biggest one, of course, is lymphedema, armpit numbness, and seromas, which we get, and then, of course, general complications. So it's something that we don't really want to see, certainly lymphedema. Axillary sampling, I'm not going to spend a lot on this. This was done in the days before sentinel node biopsy mainly, and only a few centres in the UK did it, and a few elsewhere did it. It came from Scotland, I believe, originally. And the proponents argue that it had a lower complication rate than axillary clearance because you're taking less nodes out. But nowadays we've got sentinel node biopsy, which is much more scientific and targeted. And so really axillary sampling has largely disappeared, certainly in the Western world. So I won't spend any longer on that really. So why did we start clearing the axilla in the beginning? Well, it helps give a prognosis for the patient. It helps us plan what other treatment to give. In general, if you're node positive, you're more likely to get chemotherapy, of course. But the main reason really is it's to stop regional recurrence. If you leave positive lymph nodes in the axilla, the patient's got a high risk of developing a regional recurrence later on. And there's a good seminal paper by Bernard Fisher showing that whether you did a mastectomy and clearance or just a simple mastectomy back in the 1980s, the survival was not statistically significant, but there was a hugely different rate of axillary recurrences. So the problem though that's happened is recently in breast screening, NHS BSP is the UK breast screening program, we find that only 21% of patients have positive nodes. So that means if you do a clearance on all of those, you're going to be over-treating 80% of women. They'll be having all their nodes out with the side effects for no benefit. For symptomatic cancers in the UK, the nodal positivity rate is 35%. And I do acknowledge, of course, in Bangladesh, you've got a higher nodal positivity rate. But of course, for a lot of ladies, whichever country you live in, a lot of ladies are going to have an unnecessary operation with the potential side effects. So sentinel node biopsy, I'm sure a lot of you know this, it came through originally in parotid cancer in the 1960s and then later penile cancer. And now there were different stages in the breast of using nuclear medicine and then blue dye, and now we advise combined blue dye and isotope technique. I think that's a universal recommendation, that's the gold standard. So the principle is that the sentinel node is the first node to receive lymphatic drainage from the breast and also from the tumour. And if that node is positive, then it means that the rest of the axilla could have positive nodes. On the other hand, if the sentinel node is negative, you would expect the other lymph nodes to be negative. So we should offer this operation for all patients who are clinically and radiologically negative axillae. And there's just a little picture of it. Sometimes there are two nodes, and as you see on the picture on the left, so the second echelon nodes and third echelon nodes. And I'm sure you all know what it looks like. Those who've done the operation, there's a blue node. And if we put a counter over that for isotope, we will hear a hot signal as well. So after surgery, it's sent off, usually for H&E in most parts of the world. In my unit, we use OSNA, and I'll talk a little bit about that. And if the lymph gland is negative, then we don't need to do anything more to the axilla. But if it's positive, further axillary treatment is recommended. And we can talk about those treatments shortly. There's very good evidence of how this is a safe procedure. I won't spend a long time. There's the Milan study, and there's the Almanac study in the UK. And I don't think anybody will argue that that there's safe studies with low long-term recurrence rates and much lower risks of lymphedema. As you can see there, quality of life is better. The operation could be a day case. No drains are required. So are false negatives possible? The real reality is yes, unfortunately. About 5 to 10% of patients, we don't think it makes a big difference to the outcomes, but we are aware of it. It can either be technical or biological. Technical meaning the surgeon doesn't remove the correct node, but with good training, and once you've done enough of these, that shouldn't be a problem. And we think the biological cause is because the lymphatics are blocked by tumour, so in the heavier positive nodes really. But we don't think it happens that often for biological reasons. The more nodes you take out, of course, the lower the false negative rate is, and the average is about 2. So because those patients who have a positive node require a second operation, there was a key need to have testing of the lymph gland during the operation, which would avoid 2 procedures for that patient. The patients who are negative, of course, have benefited a lot, but those ladies who had a positive sentinel node actually did worse overall because they had to have 2 operations, where in the old days they would have just had a clearance from the beginning. So what ways do we have? Well, we have imprint cytology, where you cut the node and smear the node on slides and have a look under the microscope. There's frozen sections, which you're aware of, and OSNA and other techniques using molecular methods. PCR is polymerase chain reaction. So these the 2 pictures there show a smear from cytology on the left, and you can see the big nuclei and the cancer cells. And the slide on the right shows a little metastasis and a round ball there, just under the capsule of the lymph node. But these tests it really depend on the quality of your cytologist and your frozen section pathologist. And so the papers haven't really backed up support for these. And although they were keen to start with, they're not as good as conventional pathology, really. So that's why PCR methods came available, and OSNA is the one that's used in the UK and a lot of Europe, actually, particularly Spain. And it's complicated biology, and I won't explain all that to you, but essentially it's a machine that detects an epithelial marker which you wouldn't normally find in a lymph node. It would only be on an epithelial cell, such as a breast cancer cell, and it's called cytokeratin 19, and it detects this marker. And if it picks up a marker in the lymph node, then it means there's a cancer cell in the lymph node. It is expensive. The machine that tests these nodes at £60,000, and each case is £200, pounds sterling, which is roughly the same as dollars. So basically the node is taken out, it's sent to the laboratory, the pathologist mixes it up, and you get an answer whether it's a positive node or a negative node in 20 minutes. And there's just a picture of the machine. It's about the size of a household microwave, really. So how accurate is it? Well, there's lots of studies to show that it's at least as accurate as routine pathology, and actually better than most routine pathology, because most pathologists only take 1 or 2 slices from the node. And if you see that little picture there, you can understand that just taking random slices won't necessarily pick up the metastases, particularly micrometastases. What are the controversies? Well, The studies show that the detection of macrometastasis is the same as routine pathology, because a macrometastasis is anything over 2 millimeters. But of course, it's going to be more accurate for the microscopic ones, the micrometastases, and it does pick up a lot more of these. You could say, what does it matter? Well, there's a slight difference in prognosis, not very much, but it's, the proponents would say it's nice to know if there's micrometastases or not. It might help change your oncological decision. It probably doesn't in most, but it might do in some. There are a lot of people around the world who say, well, it really doesn't matter, so we're not going to go looking for them. I think that's a contentious area, and I'm not going to debate that anymore today. Certainly the Americans believe that detecting micrometastases is insignificant, and therefore they would not routinely use immunohistochemistry on their lymph nodes or OSNA or anything else like that. So they've made a very firm statement there. Now, we've heard a little bit about in the earlier session about Z11. I think most of the surgeons will know about this, and this is looking at whether or not we need to do an axillary clearance if the sentinel node is positive. So this was a very seminal study back in about 2010, I think, 2011, and basically looking at the patients are randomized to have a clearance or no clearance, and these patients had all had a wide local excision. They were T1 and T2 tumors, small numbers of the study. It was very slow to accrue patients. But if you look at the headline figures at the bottom, the survival in both groups, sentinel node only was 92%, axillary clearance almost 92%, and axillary recurrences were extremely small in both arms. And that's 6-year follow-up. They've actually got 10-year follow-up now, which shows much the same. So it is a very contentious study. There were a lot of micrometastases in the study, almost half the patients with micrometastases. And nobody watched what the radiation oncologists were doing to the axilla. We assume it was whole breast radiotherapy, but there was speculation that they may have been getting some axillary radiotherapy. So now there's another paper which is often forgotten from 2004. There were 4 arms to this study, and most of the arms aren't of interest for today, but that bottom group of the 4 had patients having a sentinel node biopsy which was positive and were randomized not to have any further axillary surgery, and there were 210 patients in that arm, and they were followed up actually for 31 months. It's not particularly long, 2.5 months, but the number of recurrences in that group was only 1.4%, so very low. So that is another study where patients did have nothing further done to the axilla with a low axillary recurrence rate. And we're assuming, we don't know, but we assume that the reason they get low recurrences despite having a positive axilla is because they're having breast radiotherapy, which overlaps the lower axilla. They're also having systemic endocrine therapy and a lot of them chemotherapy. So because of Z11 really, and these other smaller peripheral studies, patients in the US who have a positive sentinel node and have breast conserving surgery and systemic therapy, they do not have any further axillary clearance or axillary treatment. In the UK, we have the Association of Breast Surgeons, and the guidance is that further axillary treatment is no longer mandatory in patients who are having breast conservation, who basically follow the Z11 pathway. They were the ABS are slightly worried about the T2 tumors or the grade 3 tumors or the ER negative tumors, of course, and those HER2 positive, because these are more aggressive. So caution's been advised in that group, and we've said further axillary treatment. And there was no consensus on these groups here, premenopausal women or if lymphovascular invasion was present. So the adjuvant treatment planning essentially is no longer just done on the number of nodes. Of course, we've got now a lot of molecular markers and other things like oncotype and HER2 status, etc. Now, what do you do if you are deciding to treat the axilla? If you're doing a mastectomy, so that doesn't follow Z11, or you simply, like a lot of countries, don't agree that Z11 was adequate on its own, what do you do? Do you do a level 2 axillary clearance for positive nodes, or do you do radiotherapy? Well, we now have this huge study called Amoros, which recruited 4,800 patients, and these women were randomized to have an axillary clearance or radiotherapy if the sentinel node was positive. Very good study, and nobody's really criticized in any way, and you can see there's a good number of patients having axillary clearance and or radiotherapy. And the findings were that the axillary recurrence rates were extremely low in both groups after 5 years, around about 0.5% or 1%. It didn't show any difference in local recurrence, no difference in survival, which we wouldn't expect, because as we know from Fisher's paper, even if you do not take nodes out, survival is unaffected. But what it did show, this study, was the lymphedema rate was twice in the axillary clearance group compared to radiotherapy. And this has led to a change in practice in Europe, basically. So patients with the conclusion was that patients with a positive sentinel node had a very low risk of axillary recurrence, whatever you do. But the patients who had axillary clearances had twice the lymphedema rate, and therefore we should be considering radiotherapy instead of axillary clearances. The ABS have agreed that radiotherapy is a valid alternative to an axillary dissection in these patients with a positive node. Now the Americans, because they follow Z11, they have said because of Z11, they don't need to do anything further to the axilla if they're having whole breast radiotherapy and systemic therapy. So for their wide local excision patients, they wouldn't be giving axillary radiotherapy, as you probably know. But patients who are having a mastectomy, or those with don't comply to Z11 criteria, bigger tumors, they can be considered for axillary radiotherapy instead of an axillary clearance. So they use the word "can be considered." Now there is a UK trial which was doing very well, but it's slowing down at the moment, which is essentially a rerun of Z11, but it's a bit more specific about radiotherapy fields. It also includes mastectomy patients, and it doesn't include micrometastases like the Z11 trial. What is happening in the UK at the moment? Well, there's some wide variations, as there is really throughout the world. 26 of the 92 units are using OSNA. We're not using it for every case, of course. We're using it where it's make a difference. Very few units are following Z11, and I think that's true of most of Europe and probably your part of the world. Where we get a positive sentinel node, if they fulfill the Amoros criteria, then we are usually offering radiotherapy instead of axillary clearance. And I think that would be true of most hospitals, although not all. Some units still feel happier with an axillary clearance. And the POSNOC trial is widely supported, although currently slowly recruiting, because a lot of patients just make their decision of what they want rather than going into the trial. Now, the next section is now on neoadjuvant chemotherapy, and this has been rapidly changing over the last few years. So what to do with patients having neoadjuvant chemotherapy with their lymph nodes. So we've really got two groups of women here. We've got those with clinically and radiologically negative axillae, and we've got those that we know are node positive from the very beginning, when they've got palpable lymph nodes or visible lymph nodes on imaging, which we of course then biopsy. If I talk about the node negatives to start with, originally we would carry out a sentinel node biopsy at the beginning and then send those patients for neoadjuvant chemotherapy. And then when they finish their chemotherapy, we would do the appropriate breast surgery, depending on the size of the tumor, mastectomy or wide local excision. And if the sentinel node was positive before chemo, we would then do a clearance. But if the sentinel node was negative before chemotherapy, we would do no further axillary surgery. And as I said, that was a traditional approach at the beginning. It works very well. It truly stages the patient. I say a true stage because, of course, if you do the sentinel node biopsy later, you will never truly know whether or not that patient was positive or negative at the beginning. It helps confirm whether or not you need, for some patients, whether or not you decide to give them chemo. If you find their nodes positive, you might say, because they're positive, we will give them chemo. That's a small number of patients, but there are those. And also, in some centres, it would help plan whether or not you offer reconstruction for a patient, because in a lot of centres around the world, even one positive lymph node will mean that whether the patient has a mastectomy or not, they'll have radiotherapy, and that may affect the decision to reconstruct later on. So there are some advantages, of course. The disadvantage, though, are those women with a positive lymph node are going to have 2 operations. Because we're not able to downstage the axilla, it inevitably is going to be more women are going to have an axillary clearance. We reckon at least 40 to 50% of these women having neoadjuvant chemotherapy are node positive at the beginning. And of course, the other thing, we want to get the chemotherapy in as quickly as possible, and this is going to delay the start of chemotherapy because you've got to put the patient to surgery. I've just put a little note there that if your SNB is positive before, you can't do a second SNB after chemotherapy. There's evidence for that. There is a high false negative rate. So how well does chemotherapy work to the lymph nodes? Well, if you look at all the relatively big studies of patients having neoadjuvant chemotherapy, you find the path-CR rate is about 40% if you take all patients. It's highest for those with triple negative cancers or HER2 positive cancers, and lowest for the ER positive, HER2 negative. But if you take all patients having neoadjuvant chemotherapy, you would expect 4 out of 10 to get a complete nodal response. So how many women does that actually mean then? How many benefit from chemo in avoiding axillary clearances? Well, if we assume that 40% of women are node positive, and there's a Sentina trial, which is a big study looking at this. And if we assume that 40% of women are going to get path-CR, so for every 100 women you treat, you're going to save 16 axillary dissections, which is a reasonable number. That's potentially 16 women with less lymphedema. So how accurate is it if we do sentinel node biopsy after chemotherapy? Well, there are many studies looking at how accurate it is to find a sentinel node. We call it SNB identification rate, or SIR. And ideally, you want to find the sentinel node in 95% or more patients, which is what you normally do in patients not having chemo. Well, looking at the meta-analyses, there are 24 trials looking at this, and we find that the identification rate of the sentinel node is about 90%, and the false negative rate is a little bit higher than normal, 8%, but the authors of these meta-analyses conclude that that's acceptable. So it's safe to do a sentinel node biopsy after chemotherapy. What are the issues after this approach for doing SNB after? Well, questions are what to do with micrometastases and isolated tumor cells. Most of us assume that they need to be treated seriously because they could have been bigger, they could have been macrometastases before chemotherapy. And what do you do about radiotherapy? There are some questions there for the radiation oncologists. And of course, it's harder to tell the patient their prognosis because you don't really know the true axillary staging before chemotherapy. And we don't have any good long-term studies yet looking at regional recurrence, but so far it appears safe. What about looking at OSNA after neoadjuvant chemotherapy? Well, this is seen to be safe. There are some concerns that OSNA does not detect isolated tumor cells, and there is some concern that maybe CK19 expression is affected. My own view is that in the ideal world, after neoadjuvant chemotherapy, you should do H&E with immunohistochemistry to look as hard as you can for those isolated tumor cells, because if you do find them, then they are considered node positive. But if you don't have the ability to do that, then OSNA is probably the next best option. Now, what about neoadjuvant chemotherapy and node positive women? What do we do? Well, the traditional approach, if you're node positive after chemotherapy, you would have an axillary clearance. We know it doesn't affect survival, but it minimizes regional axillary recurrences. Very safe, and it is still the commonest practice worldwide. But the disadvantage, of course, is that 40% of women, if you did that, would have a necessary axillary clearance because they're going to have negative lymph nodes. So these are women who are positive before and afterwards have become negative. So after chemotherapy, these are women who are node positive before chemo. What do you do with them? Do you go and do a clearance on everyone, or should you consider doing a sentinel node biopsy? Well, clearly, if they're still clinically and radiologically node positive, then an axillary clearance is required. Amaros never looked at these patients, so we can't give them radiotherapy. So if you've definitely got suspicion of positive nodes, you should do a clearance. If, however, you examine them and that you don't feel anything in the axilla, and if they've had an MRI or an ultrasound of the axilla and it's negative, then there's a good chance they may be node negative, and you can consider sentinel node biopsy. But how accurate is it in this situation? Well, there were 3 trials looking at this. The Sentina is the biggest, and there's 2 other trials that I've mentioned. And this looks at how accurate is it identifying these nodes and what the false negative rate is. The Sentina trial had over 2,000 patients, and I just jumped to the headlines, that the sentinel node identification rate was only 80%, so it's a bit lower than we like, and the false negative rate was considered by the authors unacceptably high at 14%. They did note that if there was one sentinel node, the false negative rate was 24%, and if you had 3 or more, it was less than 10%. And in all of these studies I'm showing you now, none of these patients had clipped nodes. Now, this is the Judy Bowie study, the Z1071, smaller study of 650 patients. They couldn't find the sentinel node in 7%, so that meant 93% they did. And 39 patients had a negative sentinel node, but a positive axillary clearance. So that gave the false negative rate for 2 or more nodes at 12%. But again, if you've got more nodes, three or more nodes, it was 9%. So it's definitely higher than patients who had not had chemotherapy. But the authors concluded they could not support doing a sentinel node biopsy after chemotherapy in these patients who were node positive. They thought those figures were not acceptable. And this is the last one of those trials. It was a smaller study, 153, but it was well conducted. And again, at sentinel node identification rates of 87% and a false negative rate of 8%. And the authors, again, were not particularly happy that those figures were good enough. So the overview of these three were that there was a low sentinel node identification rate. There was a high false negative rate, unacceptably high. Although if you have 3 sentinel nodes or more, your false negative rate was lower, as you'd expect, because you've got a bigger sample. But of course, you can't determine how many sentinel nodes there are. The patient's either got 1, 2, or 3, or occasionally 4. Most of the time, it's going to be 1 or 2, and you can't just say, I'll take 3 nodes, because they're not sentinel nodes. So other issues are that all these studies used blue dye isotope. None of them, as I said, had clipped nodes, and there are small studies, and there's no data on recurrence. So I'm sure you're aware of clipped nodes and the concept of targeted axillary dissection, and only one good study has really looked at this. These were the patients some of the patients in the Z1071 study who were node positive before chemo, and they all had both a sentinel node and an axillary clearance. And of those patients in that study, 141 had clipped nodes. But when the surgeon did the operation, he did not specifically target the clipped node. He just did a sentinel node, and once he'd done the sentinel node, he did a clearance. And they found that in the 141 patients, 107 of the clipped nodes were seen in the sentinel node, but 34 of them were not in the sentinel node, they were in the axillary clearance. So again, the false negative rates are fairly high in these studies. And the conclusion was, if you could get the sentinel node and it had the clip node in, you would have a lower false negative rate, which you'd expect. But as I said, these patients did not have that node, the clip node targeted. So has anybody looked at this? Well, there have been a few very small studies, and some of them are really a handful in each of these papers. And this is the concept of looking for the clip node that you know is node positive and removing that, as well as doing a sentinel node biopsy. So how do you find this clip node? It's quite difficult. Of course, you could use a guide wire, but radiologists are rather unkeen to put guide wires into an axilla because of the presence of the axillary vein and other large structures. People have looked at using the magnetic seeds or mag seeds, and sometimes on the day of surgery, tattoo ink. But none of these have been very, very reliable, and there's variable successes, and it varies from different institutions. And it's often difficult, even though there's a clip in the node, sometimes the radiologist just cannot identify it. And some of the studies are suggesting that in about 30% of patients, the radiologist can't find the clip node. So there are a few units doing this, but only very small, but it is something that's gaining momentum because people are trying to move away from axillary clearance. There is a study in the UK just being set up called ACNEC, and that's going to look at this in further. This is what the Americans are currently saying in their official statement, and this was from last year. So it says, based on the 1071 study, it's reasonable to consider a sentinel node biopsy in a patient with node positive disease at presentation and who has a good response to chemotherapy up front. If a sentinel node biopsy is performed, dual tracer is recommended, and an effort should be made to remove the clip node, basically, and the sentinel node. And it says if the clip node was not placed or cannot be identified, you should remove at least really 3 lymph nodes. because you get a lower false negative rate. So it's not particularly, it's not strongly evidence-based. It's a sort of hint towards that. In the UK, there's a paper which summarizes the guidelines at the moment, and I've put it at the bottom there. But it says in patients presenting with node-positive disease, the false negative rate of SNB after chemo is correlated inversely with the number of nodes removed, and it's recommended that you remove at least 3 nodes or more. And early evidence suggests marking an involved node, a clip node, makes the false negative rate lower. And that references to the paper I've just shown you. But it does say further trials are needed to confirm this finding and to standardize protocols. So this is not currently standard practice in the UK. What do you do once you've done the sentinel node in these chemo patients? Well, if you've got negative lymph nodes, you've got a complete pathological response, then we don't really have good data. And so what the UK view is, and I've underlined it there, these patients should be offered axillary radiotherapy, because we know there's a false negative rate. Some of those patients may have positive nodes elsewhere. They can avoid an axillary clearance, but they should still have radiotherapy. There are other trials looking at this going forward, and we will have the answer eventually. But if the nodes are positive, clearly that patient with a positive sentinel node after chemo, that's a poor prognostic sign, and they should have a level 2 axillary dissection. I don't think anybody would argue with that. So the key points this long talk today, I'm sorry about the length, is that patients who've got clinically node negative axillae should have a dual technique sentinel node biopsy. If you diagnose a woman at the beginning with who's a positive axilla, and you're going for surgery as the first treatment, then she should have a level 2 axillary dissection. If you've done a sentinel node biopsy, and it's positive, most units would now offer axillary radiotherapy rather than axillary clearance, because it's less morbidity, but the same survival and same very low regional recurrence. If the sentinel node is positive, I've said you could consider no further axillary treatments, as in the Americans do a Z11, as long as they've had breast conservation surgery and they have small tumors, ER positive, and they're having systemic therapy. I've shown you that sentinel node biopsy is safe after neoadjuvant chemotherapy in clinically node negative women. So it works well with the low false negative rate. But sentinel node biopsy is still controversial after neoadjuvant chemotherapy in women who were found to be node positive before the chemotherapy. And I think we need more studies to look at that. The safest thing in those women is probably to have an axillary dissection. There are future studies. Sound study we were talking about earlier on, which is looking at women with clinically and radiologically negative axillae, randomizing them to sentinel node or no sentinel node. It's a brave study. It could be practice changing. And there's another study looking at ladies who've had a positive sentinel node after chemotherapy, whether they should have axillary radiotherapy or an axillary clearance, a bit like the Amaros trial. Thank you very much.